If you want to ask any question at the end of the session, you can type the question in the chat box and we'll try to take all of them. So I'll request Dr. Rajiv to give a welcome address, please. Dr. Rajiv.
Thank you, Rawat sir, and good evening, everyone. I welcome you all to this first online CME of 2026. And this CME is dedicated to our beloved Professor Dr. A.K. Rawat, who passed away. So this first CME of 2026 is dedicated to our Professor A.K. Rawat. This CME was very meticulously planned by Dr. Rawat and his team, and I thank him and his team for such a meticulous planning. As you know, Dr. Rawat has always been doing it. And what I thought is that to make host a smaller branch to do this online CME all over MP is an initiative which I want to carry forward. And next time also we will make host some smaller branch. I thank Dr. Prince also for taking an initiative for this online streaming of YouTube on this online CME. So maybe next time we will be having an online streaming also. So thank you, Dr. Prince. And as we all know that we will be doing this every month, the last Thursday of every month, and we will be doing CMEs on different systems, and these CMEs will be of practical use for general pediatricians. So happy learning, and let's enjoy the CME. Thank you, sir.
Thank you, Rajiv. And as Dr. Rajiv was told that we have got an IP Datia as the host branch, and I'll request Dr. Dinesh Gupta to give a welcome address.
आवाज आ रही है सर?
Yes, sir, please.
मैं डॉक्टर दिनेश कुमार गुप्ता, अध्यक्ष दतिया एकेडमी ऑफ पीडियाट्रिक्स की ओर से एमपी आईएपी के द्वारा शुरू की जा रही ऑनलाइन सीएमई प्रोग्राम के प्रथम सत्र में आप सभी का हार्दिक अभिनंदन करता हूं। दतिया एकेडमी ऑफ पीडियाट्रिक का गठन वर्ष 2023 में किया गया था, जिसके संस्थापक अध्यक्ष डॉक्टर प्रदीप उपाध्याय एवं सचिव डॉक्टर राजेश गुप्ता रहे, जिनके नेतृत्व में विगत 2 वर्षों में आईएपी शाखा द्वारा शिशु स्वास्थ्य के क्षेत्र में बेहतर कार्य के लिए प्रयासरत है और जबलपुर एवं भोपाल की 24 एवं 25 की स्टेट कॉन्फ्रेंस में हमारी दतिया ब्रांच को बेहतरीन कार्य करने के लिए बेस्ट ब्रांच अवार्ड से सम्मानित किया गया था। वर्तमान में मैं अध्यक्ष के पद पर एवं डॉक्टर मनीष सजमेरिया सचिव, डॉक्टर जगराम माझी कोषाध्यक्ष के पद पर कार्यरत रहते हुए दतिया एकेडमी ऑफ पीडियाट्रिक को उत्तरोत्तर आगे ले जाते हुए सेंट्रल एवं स्टेट आईएपी के मार्गदर्शन में शहरी एवं ग्रामीण शिशुओं के स्वास्थ्य संवर्धन हेतु कृत संकल्पित है। अच्छे से अच्छा कार्य करने की कोशिश करेंगे सर। थैंक यू सर।
Thank you, Dr. Dinesh, for your all kind words, and it is really great to see that you are doing so good work in Datia. Our best wishes for doing lot of activities in Datia, and as from MPIP, we are there to help you, and whatever help you want, we're going to help you. And now,
Yes,
in the next, I'll continue the speaker for today's session. We are very fortunate to have Dr. Rashmi Das. He is a professor of pediatrics in Department of Pediatrics, AIMS, Bhubaneswar. His area of interest is pediatric pulmonology and evidence-based medicine. His major achievements and awards are: he has received V. Raju Award from Indian College of Allergy, Asthma and Applied Immunology 2025, KJR Murthy Oration Award, Indigenous Society 2025, Cochrane Kenneth Warren Prize 2023, Dr. Satya Gupta Award, NMS 2022, IP Young Investigator Award 2018, Fellowships FRCPCH, FCCP, FAPSR, and FICS. He is an associate editor of Frontier in Pediatrics, and he is managing editor of Journal of Pediatric Pulmonology, which is the journal of IAP Natural is better and is doing an excellent job, and he's editor for the past 4 years, and now the journal is just going to be indexed in PubMed. He has got nearly 200 publications and edited 3 books and written 25 book chapters. So we are very fortunate to have Dr. Rashmi, who will speak on acute and chronic cough in children. And before we start, I'll request Dr. Rajesh Gupta to introduce the expert, because we have got 2 experts in session who will be helping us in the session. So I'll request Dr. Rajesh to introduce them.
Thank you, sir, and very good evening to all of the members here. This is my proud privilege to introduce our expert of today's CME. First of all, I would like to introduce Professor Dr. Rajesh Tikka, sir. He is currently working as a professor in Department of Pediatrics, Gandhi Medical College, Bhopal. He has been trainer for many national level activities of the IAP like BLS, ALS, NRP, NSSK, and he is faculty of the asthma training module as well. He has been serving as the Honorable Secretary General of the MP-IAP during the period of 2020 to 2024, and currently he is a CIAP Executive Board member for 2026. Another expert among us is Dr. Abhyakt Agrawal. He is a consultant pediatrics and allergy at Jabalpur. Now I invite our speaker for today, Dr. Das, sir. Thank you. Over to you, Dr. Das, sir.
Yes, sir. Sir, is my screen visible now?
No.
Achha, one
Yes,
second.
yes, it is visible.
It is visible.
Make it full screen, please.
Yes, sir, yes. And I'm audible also?
Yes, you are audible.
So very good evening, respected Rawat sir, Sangvi sir, esteemed members of MP-IAP. Thank you so much everyone for this kind invitation. Actually, I'm really privileged to be the opener batsman for this academic extravaganza that has been planned over here. And thank you so much, Rawat sir. Actually, I have a long association with Rawat sir and Sangvi sir. And whenever I get an invitation, I don't have the guts to deny that, okay, I don't have time. So anyway, like I will cut short all other assignments and I will tell yes to them. There is no second thought. So when sir messaged me that we are opening with the CME on 29th, are you free? In next 2 seconds, I told without second thought, yes, sir, I'm there. So thank you so much, sir. It is a very important topic. Okay, so there has been much discussions with the recent tragedy regarding the cough syrup. So everybody is curious about to know about cough and how we can effectively treat this cough. So before that, we should know what are the different types of cough, and so that's why the CME probably has been planned. And the information I'm going to give to the audience has been collected from different guidelines, national guideline IAP, the international guidelines, and reliable textbooks and some journals. So whatever I am going to tell you is the truth, and I will not use experience unless somebody asks me what is in your experience. Okay, so whatever I'll talk of science. The CM is about cough. Cough means, so it is not a kind of theoretical, you have to imagine something. You have to see the type of cough, or you have to listen to make some diagnosis. So before I take you through the details of acute and chronic cough and how to approach, so let us hear some different cough sounds. Okay, so there are many different cough sounds, but I have taken 3 prototypes, and so there are 3 videos. I will play one by one. And the extreme left is an infant of 3 months age. The mother had some chronic cough. The child was fine. Now he is having cough, which is non-remitting and continuously coughing, that is affecting the feeding. The middle video is of a child who is 3-year-old boy who had some URI-like symptom. Now he is having some cough, which is abnormal in nature, and the parent has brought the child to the hospital for consultation. The third video is an adolescent boy who is having some bizarre type of cough, and no response to treatment, and there is loss of school days. So parents are really worried what is happening. So investigations have been done, but there is no diagnosis. So let us see one by one.
There is no sound.
Sir, no sound.
Yes.
Oh. So what to do, sir? Because the sound is, I'm able to hear the sound. Probably the video is played, but there is no sound.
You can try once
Video is
again.
video is there, but there is no sound in that.
Oh, but I am able to hear actually. One second.
Okay.
Let me
You can
try
try the
once
second.
more.
You can try the second, sir.
Yeah, let me try. Is the sound coming?
No.
No.
No sound. Achha. But I am able to hear actually. So the video is being played.
Increase the volume.
I have actually 1 second. One. Okay, so I'm making the full volume. 1 second.
अब प्ले करिए.
Yes, sir. 1 second. So I'll just reshare once actually. Right. Second. Yeah. Is it audible now, sir?
No. There is no sound. Probably there is some issue. तो आप आगे बढ़ जाइए.
ठीक है sir. ठीक है. So this was because the child, as you can see in the video, the child is continuously coughing, and so the diagnosis of pertussis, and the child beautifully responded to a course of azithromycin, and the mother had actually pertussis, and this child after a URI some kind of cough, and this is classical brassy cough, and the child had croup, and it responded to this dexamethasone. And third child, so from the video you can easily know. So you see, so when somebody asked, okay, you start coughing, he's coughing, and he's okay. So it was a habit cough, and the child needed some psychological counseling. Parents were anxious, and now the child is fine. So if you see, so there are different types of cough. So in order to make the diagnosis, you have to know the history.
Excuse me, sir.
And yes. Yes. Okay. So, and you have to see the child coughing, or if the child has not, the parents have not brought the child, or they have directly come for consultation, you can ask them to record the video. So, if the child is not coughing in the office or the clinic, so you can ask them to record the video and show to you, so that you can make the diagnosis. So, the cough sounds are like sputters, and if you see, you can easily make the diagnosis. So, there are some facts about cough. So, it is a sound produced by an attempt to expel an irritant during a forceful exhalation. So cough is a protective reflex basically. So when our airway is irritated and there is some obnoxious material, so naturally the body will try to expel it. And this protective mechanism is the cough. Many times parents usually confuse it with the cold actually, but cold cough are different, and you have to categorically ask whether it is cold or cough. So cold is a nasal discharge or a blocked nose basically. Okay. And cough is a very common phenomenon in children, and a normal child can have 10 to 11 episodes of cough per day, which is absolutely normal. Okay. And this cough is a symptom. It is not a disease actually. So fever is a symptom, not a disease. So the same principle applies to the cough also. So you have to take a very good history and do the proper examination to reach the diagnosis. And also you have to witness the cough basically, as I showed you in the video. And there is a reflex arc of cough in the body, and this reflex arc starts from the cough receptor and it goes to the brain where it is processed. And these cough receptors, they are present in the airways as well as outside the airways. That means in the extrapulmonary tissues. So if you see in the picture, Okay, so the green one is the cough center, and the bold blackish dots, so they are the cough receptors. Okay, so the cough receptors are present in the pharynx, nose, the supraglottic airways, trachea, bronchi. Okay, and in the extrapulmonary tissue, they are present in the external auditory meatus, as you can see, esophagus, diaphragm, pericardium, and the stomach. Okay, so the image beautifully depicts the locations of the cough receptor. Please remember the pleura, they usually do not have cough receptors. The small airways, cough receptors are present, but they are very, very few in number. So the dictum is that the cough receptors, where they are abundant, so the pathology there will produce cough. Okay, so there are some pulmonary conditions where cough may or may not be present. So you have to be very, very careful. Cough is not synonymous with involvement of the respiratory system. That is the message. So let us discuss some definitions. So what is acute and chronic cough? So there was much confusion regarding the definition of acute and chronic cough. So previously people were telling, okay, more than 2 weeks, somebody told, okay, more than 3 weeks, somebody told 3 to 8 weeks. So there was a kind of very vague definitions, and it was difficult to follow in the clinical practice. So the American College of Chest Physicians, the American Thoracic Society, and the British Thoracic Society guideline, they told that let us follow a uniform pattern. Okay, because cough will give you some hint, it will not lead directly some diagnosis. So you have to interpret cough in a background of history and examination. So they decided that let us classify into 2 types. So acute means the duration lasts for less than equal to 4 weeks. Chronic means more than 4 weeks. So there is a clear-cut distinction. But please remember, there may be some overlap. Okay, some normal cough like post-viral cough may sometimes last for 4 to 6 weeks, but in that cough the child will be improving. So when the acute cough lasts for, like acute cough, it will last for less than 4 weeks, and chronic will last than more than 4 weeks. What is acute, severe, or life-threatening cough? When the cough is present in a background of red flag signs. Okay, so that I'll be showing you later. And specific cough means the cough indicate underlying disease. Okay, so there are different types of cough that we'll discuss in subsequent slides. So that will tell you that if this cough is present, probably this is the underlying diagnosis. So that is known as specific cough. So today's topic is regarding approach to acute and chronic cough. So how to approach? So you have to discuss certain points whenever you are seeing a child with cough, whether it is acute or chronic. The first and foremost is the cough characteristic. What is the quality of cough? What is the pattern of cough? Second is, what is the clue to the origin of the cough? That means the anatomical localization. Third is associated features. So whether cough, it is an isolated cough, or there are some other features present, whether other organs are also involved. Okay, and whether red flag signs are present. Third is, you have to take a very good history and do a focused clinical examination. And suppose you are not getting any clue, okay, your history examination is not supporting, you are not sure what is happening. So naturally, you have to resort to some important investigations. So they will supplement your clinical examination and history. And finally, what happens sometimes, you don't get any diagnosis. You start some empirical treatment and the child responds. So in that case, you retrospectively make a diagnosis. Okay. So these are the points you have to follow whenever you are approaching any child with cough. So let us discuss one by one. First is cough characteristic. Okay. So left side, I have mentioned certain characteristics that will indicate possible etiology. So dry cough, it is common in case of viral upper respiratory infection, asthma, and interstitial lung disease. Wet cough, wet means productive cough. So whenever the child is coughing, there is some sound. Wet cough is different from noisy breathing because many times parents will make you confused. So categorically ask them, when the sound is coming, it is during breathing, like inspiration, expiration, or when the child is coughing. So in wet cough, when the child coughs, the sound will come. Breathing will be usually normal unless there is some added sounds. Okay, or the child is producing sputum. So wet cough indicates there is some underlying suppression or problem in the mucus handling. So classically it is seen in protracted bacterial bronchitis, cystic fibrosis, PCD, bronchitis, sometimes in pneumonia also, and primary ciliary dyskinesia. Third is staccato cough. Okay, so sometimes you may witness. So classically it is seen in case of infection by atypical organism, that is chlamydia, classically described, or pertussis in infants less than 6 months. So in infants less than 6 months, this paroxysmal cough with whoop is classically not seen. That is seen in older children or adults. Okay. So infants with pertussis, they may have staccato cough. So what is staccato cough? So they are short bouts of discrete cough intervened by inspiratory phase. So child will cough like this. So like somebody is firing the machine gun. So cough, there is inspiratory sound. Okay, so like that. So this is staccato cough, and it goes like a chain reaction. Okay, so that is regarding the staccato cough. So it will respond to your treatment with azithromycin or clarithromycin, and it is a spotter kind of thing. When you see the child, you can easily diagnose. Then barking cough. So barking cough happens in croup. And barking cough originates from the larynx actually. So croup is laryngotracheobronchitis. So if there is more of laryngeal involvement in croup, patient will have barking cough. Brassy cough again seen in croup and tracheal pathology. Please remember, brassy cough indicates tracheal pathology. Again in croup, it is laryngotracheobronchitis. So if larynx involvement is less, tracheobronchitis involvement is more in croup, instead of barking cough, so patient will have brassy cough. So that you have to remember. In addition, tracheitis or any tracheal pathology, patient will have brassy cough. So in the second video, I could not make you hear the sound. So it is a classical brassy cough and the child had croup. Actually, honking cough, it is a Bizet type of cough, very irritating cough. Okay, no specific character, and the patient type of conditions, or the child is having habit cough. So because of some psychological stressors. Origin will give you the clue regarding the underlying pathology. Okay, so origin means what is the anatomical localization cough. So cough might originate from the airways, from the lung parenchyma, from the pleura, from the interstitium, or from the heart, because that is inside the thoracic cavity. Okay, so based on some combination of sign symptom, we can make a diagnosis about the anatomical localization. So please remember, in airway environment, cough is more actually. Patient will continuously cough. Rest of the sign symptoms are less. In lung parenchyma involvement like pneumonia, cough will be there, but it will be less. In pleural involvement, cough is plus minus because pleura doesn't have much of the cough receptors. Okay, so it may be because of the nearby irritation, so that will happen. Interstitial involvement, again, patient will not usually have cough, like interstitial lung disease. In cardiac involvement, like some acyanotic congenital heart disease, pulmonary edema, patient will have cough. Okay, it is not like very high or very low, so in between cough. Fever, airways, usually less. Patient will have mild grade fever or no fever. And in lung parenchyma involvement, like pneumonia, patient will have a high grade fever. In pleural involvement, effusion empyema, patient will again have high grade fever. Interstitial involvement, again fever will be less. And cardiac involvement, usually patient will not have fever. Breathlessness. In airway involvement, particularly the upper airway involvement. Okay, so airways can be upper or lower. That means larger or smaller. So whenever there is a larger airway involvement, breathlessness will be less. So cough more, out of proportion, breathlessness is less. So it is upper airway. But if there is a lower airway involvement, for example, patient is having bronchiolitis. So lower airway have less number of cough receptors. So patient will have breathlessness more, but cough is less. Okay. Lung parenchyma, breathlessness will be more compared to cough. Pleura, plus minus. If it is a massive effusion, then patient will have breathlessness. Otherwise, patient may not have breathlessness. Interstitial involvement, ILD, patient will have breathlessness. Exercise dyspnea, exercise intolerance, everything will happen in interstitial lung disease because there will be hypoxia. Cardiac disease, plus minus. Okay, so it may or may not be present, but if patient has pneumonia, superimpose on some kind of underlying heart disease like VH with pneumonia, patient will have breathlessness. Okay, but not pure because of the heart disease. Chest pain, classically seen in pleural disease. And if there is pneumonia, so severe pneumonia, sometimes patient may complain of chest pain, but it is not a usual symptom. Chest pain is very common in older children with pneumonia, but in pleural involvement, patient will complain of chest pain or discomfort. Interstitial involvement, usually no chest pain and not in cardiac disease. And when you look at the child, you will see some chest retractions. So if there is a suprasternal retractions, then it indicates there is a extrathoracic larger airway obstruction, maybe at laryngeal level, your trachea, or maybe in the supraglottic airways. If there is a subcostal retraction, it indicates intrathoracic smaller airway involvement. Okay, so depending upon which part is involved, you will get a permutation combination. Long parenchymal pneumonia, you will have intercostal involvement more. Okay, so if it is severe pneumonia, like kind of there is a large lobar consolidation, you will get subcostal retraction and rarely suprastinal retractions. Pleura, usually retraction is not seen unless it's a very severe one. Interstitial lung disease, you will have an intercostal retraction. Cardiac disease, you will have a combination of intercostal as well as subcostal retractions. So with a combination of findings, you can localize where is the pathology. Then, most of the time, you will get some noisy sound or added sound. So if they are present, again, they will provide you some additional clues. So on left side, so these are the different types of noisy sounds or added sounds. The first one is snuffle or snort. The site of origin is nose or nasopharynx, and it is seen in those with nasal block, either because of cold or rhinitis. Stutter or snoring. It usually indicates involvement of the supraglottic airway, that is oronasopharynx. Again, it is seen in nasal block or adenoid hypertrophy. Okay. Stridor, it indicates extrathoracic airway involvement. So it could be glottic or subglottic and trachea. Please remember, in glottic involvement or the laryngeal involvement, patient will have hoarseness of voice along with barking cough. So whenever there is a cough with hoarseness of voice, that means it is originating from the larynx or glottis. Okay. Subglottic and trachea, patient will have normal voice. And there will be brassy or honky cough. Okay. In supraglottic airway, cough will be normal, voice will be normal. So what are the examples of conditions where stridor will be seen? Croup, airway malacia like laryngomalacia, tracheomalacia, bronchomalacia. Subglottic pathology. There is a subglottic stenosis or there is a subglottic hemangioma. Tracheal compression or narrowing. Either there is an interluminal or extraluminal compression or narrowing. Any lymph node compressing trachea, there is a vascular malformation. Okay, or there is a tumor inside the trachea, there is a foreign body. So patient will have this type of cough. Wheeze and rhonchi, they indicate intrathoracic airway involvement. So classically seen in asthma, bronchiolitis, foreign body inhalation or airway compression. So any extrathoracic airway, like intrathoracic airway compression, secondary lymph node mass will also produce wheeze and rhonchi. Okay, rattling sound, rattling tells you that there is some secretion which is moving inside the airways. It could be larger or smaller airways, intrathoracic or extrathoracic. And classical examples are bronchiolitis, bronchiectasis, and protracted bacterial bronchitis. These are the conditions where you will hear a rattling kind of sound. So it is a musical sound. Okay, looks like some secretion is moving. Sometimes it will get clear. Patient has cough or there is a vomiting, it will disappear. Okay, that is rattling type of sound. But wheezing rhonchi, they usually don't disappear after the patient takes out the sputum. Grunting crepitation, they indicate alveolar or long parenchymal involvement and seen in pneumonia or pulmonary edema. Epiglottis, please remember, there are no cough receptor. So epiglottitis patient, they do not cough actually. It is a kind of very useful information because epiglottitis usually get confused with your upper airway involvement like croup. So in epiglottitis, patient will not have cough. The patient will be toxic look, fever, and drooling. Okay, cough is absent or very, very minimal. So next, what are the common questions you have to ask in order to have an idea regarding the underlying diagnosis? So left side, I have mentioned the questions, and on the right side, these are the interpretations. So questions you have to ask: is cough a predominant symptom? If yes, it suggests an airway disease, because cough, severe cough, is a marker of airway disease. If yes, then you have to ask further whether it is dry or wet. Upper airway involvement, dry cough. Lower airway involvement, it is a wet cough usually. Is there a history of recurrent cough? Is it aggravated after exercise or which season? If answer to this question is yes, probably it is a case of reactive airway disease. Okay, like asthma. Is there a personal or family history of atopy? Again, atopic disease. Is the cough worse at night? If yes, then whether it worsens soon after lying down. If yes, then it could be upper airway cough syndrome or post-nasal drip syndrome. Both are synonymous, but the more recent terminology is the upper airway cough syndrome. PND was the older nomenclature, post-nasal drip. Okay, or aspiration. Aspiration from above, that is the oropharyngeal secretion because of some pathology that will get aggravated soon after lying down. But if it is getting aggravated in the late night or early morning, that indicates there is some underlying reactive airway disease like asthma, or there is aspiration from below. Aspiration below means GARD. Okay. Then how is the onset? Is the onset sudden or hyperacute? It indicates probably there is a foreign body inhalation. So you have to ask the parents' history, whether there was some choking, what the child was doing when the cough started. Okay, you may get some clue. And the cough started and evolving over few hours. So that also indicate probably it is a case of a reactive airway disease. So these are common conditions, but there may be some deviations also. Then how is the progression? The cough started, how it is progressing? Is it recurrent episodic? It indicates reactive airway disease. Is it progressively worsening? So it indicates it could be pertussis or some mediastinal mass which is compressing the airway, like mediastinal lymphoma, or there is a tubercular lymph node that is compressing the airway trachea. So there the cough will progressively increase. And many times you will get children who are having fever, cough, and cold. And in fact, that is the most common cause of your OPD visit. So how to get a clue from that? It will depend upon the sequence of appearance of the symptom. So if there is high fever followed by cough and cold, or vice versa, child had cough cold for a day, suddenly developed high spiking fever, or high spiking fever along with cough cold, that indicates some viral infection. Cough cold is there, but fever is very mild. It indicates reactive airway disease. Okay. Cough subsiding soon or within few days of fever indicates viral infection. Cough persisting or taking longer to resolve after fever. Cough is persisting. Parents will tell that he had some viral infection, but his cough is persisting. It is not remitting. So probably the child had some underlying disease, or probably the child is having asthma, which was not detected earlier. So in those cases, after the virus infection has gone, patient will have persistent cough. Okay. Another question is the cough disappearing during sleep or is loud and bizarre? You are not able to know the pattern actually. Very bizarre type of sound. And child is otherwise looking fine. He is not concerned about this cough. And in psychiatry, a term used is the la bella indifference. That means patient is not worried about his concern. You will see parents are more anxious than the child. And when you take the history, they will say he is not going to school. And during night time, it is totally disappearing. So that indicates it is a habit cough, and probably there is some stressor. So these children has to be referred to psychiatry to allay the underlying stressor so that the child can be fine. No investigation required in this case. If there are associated symptoms like chest pain, breathlessness, vomiting, palpitation, swelling, dysfunction, or red flag sign, then you will get some clue regarding underlying specific diagnosis. In the history, you have to further poke into other informations. Okay, so these are the information additional you can ask. Birth history, whether the child was a preterm, whether there was some asphyxia, or it is a IUCR baby. Okay, that means the baby is having some problem from the beginning. So now probably cough maybe because of that problem. So in preterm baby, the lung size is small, the airway size is small. So with trivial kind of insult, they will have more cough. In asphyxia, there may be some dysfunction, oropharyngeal dysfunction. Okay, that will also cause cough. So birth history will give you clue regarding the cause of cough. Then prior history of surgery, okay, any thoracic cavity manipulation, exposure to smoke, cooking gas, and pollution, pollen. Many times we forget regarding the environment, inside the house and outside the house. Suppose a child is having cough, dry cough, persisting, not responding to any kind of treatment. Ask the parents to get a picture of the house and what is there around the house. Many times you'll get a clue. So they are residing in a place which is nearby the highway, or some kind, the place is crowded, or it is near to some harvesting kind of like some paddy fields or something like that. Or they are staying in a area which is swampy, and you will see there are fungus or the walls are dirty actually. So then you have to tell them that they have to avoid this, because these will act as triggers to cause worsening of the cough. So many times you do not talk of pollution inside the house, condition of the house inside or the outside, but these are very important factors that has to be looked into. Then any history of hospitalization that indicate probably the cough is significant. Requirement of oxygen. Okay, that means probably there is some serious underlying condition. Intubation, ventilation, again it tells that there is some serious underlying condition. And if there is a past history of intubation, patient is having cough also, probably he is having underlying subglottic stenosis. So this will give the clue regarding the cause of cough. History of immunization. Suppose the child has not received immunization against pertussis or other like kind of agents. So child will have recurrent infection for that, and child will also have a recurrent cough. Any pet at home. So pet exposure is very, very important. So if there are pet at home, again, it will cause some allergy and there will be continuous cough or it will exacerbate the asthma. Growth pattern, how the child is going. Okay, so always document in your OPD sheet. Okay, whether the child is gaining weight or not. Child may look fine, but if he's not gaining weight or there is a weight faltering, that also indicate probably there is a serious underlying disease. It may likely that the disease has just started, so growth is normal or it is static. But as the disease progresses, the child growth will flutter. So it is very important to note the growth parameters or the anthropometry parameters. And always do a very good examination. All detailed examination has to be done. Okay, upper airway, lower airway, your areas from where the child may get cough, like your already have shown you the cough receptor, their location. So you have to examine the cardiovascular system. Okay, you have to examine the ear also. You have to palpate the abdomen. So everything you have to look for. Along with that, also look for the pointers like the dysmorphism. So any child who is dysmorphic will have some underlying reason for cough. Okay, so important point is that the physical findings should not be missed. Physical findings will supplement your history actually. Role of investigations, upfront you may not do, but whenever you are not able to reach a diagnosis, you are not sure, or there is some kind of confusion, what could be the underlying cause? So naturally you have to resort to different diagnostic modality, both in acute and chronic cough. So these are the investigations, CBC, ESR, CRP, PCT, they will help you in bacterial viral pathology. Okay, throat or nasal swab, so they will help you in getting whether it is a bacterial viral URTI, and for specific infection, you will provide specific treatment. Sputum or gastric aspirate, gastric lavage for CPNAT. Suppose the child has been chronic cough, there is a weight loss, there is a history of contact with tuberculosis, naturally you have to do these. Chest X-ray, it is not always indicated, but whenever the child is in persistent non-repeating cough, chronic or recurrent cough, or there is a history of foreign body aspiration doubtful, then you have to naturally go for a chest X-ray. CT MRI, these are the advanced modality of investigation that has to be done in tertiary care center. You should not do and say because many times it may not have been done properly. Okay, bronchoscopy, naturally it helps you in airway evaluation, particularly in chronic recurrent cough or whenever there is a suspected foreign body aspiration. Spirometry, when you are not sure there is a persistent dry cough or the child is having some associated symptoms, so that will help you in making whether it is a obstructive or restrictive lung disease. 2D echo, very, very important. It will tell you whether there is an underlying heart disease. Please remember, many times you will not be able to hear the murmur, particularly small infant. They will be crying, they will be irritable. And if the sound is basically large, sometimes you may not get, or there is a complex heart disease. Many times you will not be able to hear the murmur. So in small infants, young children, when you are not sure of diagnosis, better to go for a 2D echo. Barium shallow GR scan, again, if there is swallowing dysfunction, aspiration, so naturally you have to do it to document it. And finally, suppose you are not able to know or that the child is having some dysmorphism, you have to go for genetic testing. Okay, so these are the role of specific investigation and that will supplement your examination and history. Please remember, more severe the cough, lesser chance of bacterial infection. So cough is more in case of viral infection compared to a bacterial infection because the viruses affect the large airways, the upper airways. Bacteria usually affect the lower airways commonly, except your few things like tonsils, okay, or your epiglottis where there is no receptor, so they will have less cough, okay. And more the cough, lesser the need for chest X-ray, exception to the airway foreign body. So these are the dictum you have to remember. Then coming to what are the common disorders that present with acute cough. So these are the common conditions. The most common condition you see in clinical practice is the post-infectious cough syndrome. And the organisms are commonly viruses, atypical organisms, or the pertussis. Second, aspiration syndromes. It could be intrinsic or extrinsic aspiration, like reflux, GERD, some aerodigestive communications like tracheostomy, fistula, and clefts, or extrinsic, that is the foreign body. Okay, asthma, it is a very common condition. Upper airway cough syndrome or post-nasal drip, they are also a cause of acute cough, but most of the time they will cause chronic cough. Then how to approach a case of acute cough? So first you have to make it sure whether it is it cough or cold. If it is cough, is it significant? Are there red flag signs or risk factors? So what are the red flag signs? Daily moist or productive cough, feeding difficulty, choking, drooling, chest pain, chronic or exceptional dyspnea, hemoptysis, persistent voice change, failure to thrive, digital clubbing, hypoxia, cyanosis, or craniofascial dysmorphism. So these are the red flag signs. If they are present, so then you have to act accordingly. So cough is acute. Is it life-threatening? Possible causes are foreign body aspiration or severe airway malacia. That is severe laryngomalacia, tracheomalacia, bronchomalacia, or there is a massive aspiration. Non-life-threatening, is it pulmonary or extrapulmonary? Pulmonary, isolated cough, so you have to act accordingly. If there are additional symptoms like breathlessness, chest pain, okay, so it will, or hypoxia, it will tell you what are the possible underlying cause already that we have discussed. If there is a multi-system involvement, it will tell you there may be mucosal dysfunction like CAPCD or immunodeficiency or pulmonary manifestation of other systemic disease. Non-pulmonary cardiac conditions will have cough, GI causes like GERD, neuromuscular causes by causing aspiration or habit cough. So these are the non-pulmonary causes that will cause non-life-threatening cough. So this flowchart tells you how to approach a case of acute cough. Second, coming to the chronic cough. Okay. So chronic cough etiology can be broadly divided as per the age of the children. Is the child less than 5 years or more than 5 years? Okay, there may be some overlap, but these are the common conditions. Child less than 5 years, most common cause are infection. Okay, and the most common infection is tuberculosis. Then gastroesophageal reflux disease, congenital malformations, asthma, protracted bacterial bronchitis. Patient will have persistent wet cough. You may get some rattling sound. Passive smoking and environmental pollution. Whenever you are not getting anything, there is a persistent dry cough. Always rule out whether the child is having continuous exposure to pollution. Foreign body inhalation. Okay. If there is a retained foreign body, that will also cause chronic cough. And a retained foreign body usually causes a wet cough because there is an underlying infection. Older children, asthma, again infection, upper airway cough syndrome or post-nasal drip, secondary to your nasal block, rhinitis, or chronic bacterial sinusitis. Okay. Then protracted bacterial bronchitis, passive smoking and environmental pollution, bronchiectasis, or psychogenic cough. So these are the common causes in children more than 5 years. Then how to approach a child with chronic cough? Okay. In all children with chronic cough, perform chest X-ray and spirometry whenever possible. Address parental stress and concern. Address exacerbating factor like smoke and pollutants. Minimize use of medication. Consider condition not to be missed during history and examination. Is the cough wet or dry? If dry, follow the left path. Are red flag signs pointing to specific cause present? No. Consider watch and wait approach. If the child is fine, it is not causing trouble. Asthma, post-infectious cough or body proptosis and treat accordingly. If red flag signs are present or specific pointers are present, you have to manage accordingly. Okay. So in the left panel, when you are following the child, review the child after 2 to 4 weeks. Is the cough resolved? Then keep the child under follow-up. If the cough has not resolved, even after watchful waiting or treating the condition, then you have to refer the child to specialist. On the right side, if the cough is wet, are red flag pointing to specific cause present? If yes, you have to act accordingly. Get some clue and do the necessary test as we discussed. If no, consider protracted bacterial bronchitis and give 2 weeks of empirical antibiotic, and the most common antibiotic is the amoxicillin at a dose of 40 to 50 milligram per kg per day. And after 2 weeks, review the child. If the parents tell that the child has responded, cough is reduced by 50%, but still persisting, give another 2 weeks of antibiotic and evaluate after total of 4 weeks. In protracted bacterial bronchitis, the child will respond to a 4-week course of antibiotic. But after 4 weeks of antibiotic, still if the cough is not changing, it is still persistent, naturally you have to think of other possibility like any chronic underlying mucosal dysfunction, CF, PCD, conditions like that. Okay. Child with chronic cough with presence of key red flag features, abnormal X-ray or abnormal spirometry if the child can attempt. If none of these are present, in the spirometry, you are documenting bronchodilator reversibility. Then the diagnosis is asthma and you have to treat. Suppose you have given treatment after seeing the reversibility, but the response is poor. So you have to correct those factors that can lead to poor control of asthma. But still that is persisting. So you have to subject the child to further investigation. At the same time, you have to rule out asthma mimickers. Okay. So asthma mimickers like protracted bacterial bronchitis, chronic infection, bronchiectasis, aspiration, interstitial lung disease, airway abnormality, or cardiac disease. So these conditions may mimic asthma. The patient will have a combination of wheezing. Sometimes you may get crepitations. And these patients, they will not classically respond to bronchodilators. So I'll tell you something regarding the cough mixer, because many times the debate is how to treat the cough and what about the cough mixer. So please remember, fixed dose combination like expectorant, antitussive, bronchodilator, not satisfactory because of difference in time course of action of the components and liability for indiscriminate use. Okay, mixture we should not give because the causes of cough are different, their origin is different. So mixture will not act actually, and their time course of action different, they act by different mechanisms, so it may cause problem. And fixed dose combination of many combination actually banned in India, but still they are marketed actually. So then how to treat and what to prescribe? This is a $1 million question, and this is the last slide of my presentation. It is very important that you should be able to know the origin of the cough. After taking a very good history, physical examination, and taking into account of the additional symptoms. Okay, because it will tell you what is the underlying diagnosis and what therapeutic decision you have to take. URTI, they are benign and self-limiting. Counseling is very, very important rather than prescribing medicines. Bacterial infection, which are classical, like pharyngotonsillitis, there is a pause point, large tonsil, or there is diphtheria, sinusitis, pneumonia. Obviously, you have to give antibiotics. Inhaled mucolytic agents like hypertonic saline, they have role in specific acute or suppurative lung disease like CF. Okay. Antihistamine, saline nasal drop, steam inhalation, they have role in allergic rhinitis or postnasal drip or sinusitis. Beta 2 agonist only in children with airflow obstruction. That is documented by your spirometry, and if the child is not able to do spirometry, there is a persistent dry cough, you can give a trial of bronchodilator and evaluate the child. After 6 weeks, if there is a response, so retrospectively you can make a diagnosis of asthma. And treatment of underlying cause in both acute and chronic. So once you get to know the condition, you have to treat the underlying disease before getting rid of this cough. Okay, so this is the flow chart or the information. If you follow, almost more than 95% cases you can treat effectively and as per the evidence. 4-5% cases you will face trouble, but again you have to use your clinical acumen or experience to treat those children. So with this, I have come to the end of my presentation. Because 40 minutes for acute and chronic cough, I thought I'll give you some idea so that whenever a child is coming to you, you can approach it kind of as per the evidence, as per the guideline, and it will be very helpful to you. So thank you for your patient hearing. And if there is doubt, I can take it now. Thank you so much, sir.
Thank you, Dr. Rashmi, for an excellent presentation, giving a bird's eye view of how do you approach a child with acute or chronic cough. So before we open it to this discussion, let us have a view of our experts. I'll request Dr. Rajesh Tikkus to give his view in short. What is his approach to acute and chronic cough?
First of all, I would like to thanks Dr. Rashmi Das for this excellent deliberation. And I think after his deliberation, many of us or the practicing pediatrician will be more comfortable while dealing and while approaching to the cases of cough. And we all know that cough is a very important symptom in our day-to-day practice, OPD practices, and many of our pediatricians are worried about the management of the cough. And it is very you are very correct that we have to, many a times we have to just consult the parents and we have to just give the some mild symptomatic drugs. But sometimes it is quite difficult to manage the cough and consult the parent. And you have clarified all those things. So once again, congratulations. What I have seen in today's scenario is that many a times after the viral infection, the child is developing the conducted sounds. And parents are also very much concerned about they are having the conducted sounds or gadgadahat ki awaaz. So what do you think? And I personally feel the pertussis are not so much nowadays in view of so much of vaccination. So what is your take as far as the long-term continuation of respiratory sounds in today's scenario?
Yeah, so that is in fact a very common problem because conducted sounds is very common in children actually. And if you are sure of conducted sound, it is nothing else, nothing to worry actually. Conducted means you're getting conducted from the upper airways. And the most common underlying condition is there is a nasal block. Okay? Or there is a rhinitis. Conducted sound usually doesn't seriously signify an underlying disease. That's why it is conducted sound. It is not a specific sound. So conducted sound is very non-specific. So if you are pretty sure you have seen the child, general condition, you have witnessed it, just parental counseling needed, and you can just advise some saline nasal drop to keep the nose open actually.
Yeah.
So that much you can do. And always, whenever anything which is lasting for, let's say, 2 weeks or 3 weeks, better to keep the child under follow.
Yeah.
To see the evolution. Okay. And tell them that, okay, these are the red flags and danger sign. When any of these happen, better you come to me. So if you educate the parents, tell them everything clearly, so they will have faith on you and they will not trouble you actually.
Also, we have seen that there is increased proportion or increasing number of atopic patients nowadays, and the pediatric population are having increasing number of atopic problems or reactive airway disease. What is your take on that particular thing?
No, you are very right actually. I will tell you, like in Bhubaneswar, I came in 2013, I joined AIMS. Weekly, we are seeing few asthma cases, maybe weekly 10 to 15. Nowadays, per day, we are seeing 10 to 15 because construction is happening in Bhubaneswar and the Bhubaneswar air quality has worsened. You cannot imagine it is competing with Bhubaneswar. In some place in Bhubaneswar, it is nearly 400. You cannot imagine. But nobody is bothered actually. So environmental pollution is a major cause of this dry cough, irritating cough, and excessive asthma. In fact, in future, you will see less like number of this post-infectious cough compared to asthma. Like, I don't know if the pollution increases like this, so that will be more significant. So that is happening actually. So that's why I told, whenever you are not sure what is happening, patient is not responding, it is non-remitting cough, particularly dry cough, always take environmental history and see where they're residing, their in-house condition, out-house condition. Many times you don't ask. Now you tell me how many pediatricians take a detailed history regarding the environment and the house. Nobody usually takes because either we are busy or we are not concerned. But there is something which is actually causing trouble to the child. So that is very important in case of persistent dry cough or your non-response to your bronchodilators. Okay. So it is not like that all children, they will show a bronchodilator response. It depends how the child is doing the spirometry. If the spirometry is not done properly, you cannot interpret. Many times outside the spirometry is done, reported as normal. But once you see the graph, it is not done properly. So it is very important that whenever you are interpreting something, it has to be interpreted properly. We cannot see that, okay, spirometry done, somebody reported normal, it is normal. No, it is not like that. So we have to examine the child, see everything carefully before taking a decision. And whenever we are not sure of something, we can refer the patient, we can take the help of the colleagues also.
Okay, thank you.
Thank you, Dr. Rajesh, and I request Dr. Avek to say a couple of words. Dr. Avek, are you there? Okay, so he probably is not there. So we'll take a couple of questions which are there in the chat box. First question, Dr. Rashmi, is that sometimes child comes with cough and vomiting after cough. So what do you think would be the cause? Very commonly, you get a history that child has cough and followed that he has got vomiting. So what are the common causes for this particular thing?
So, sir, that is post-ossive vomiting. Actually, post-ossive vomiting can be normal because small children, when they cry, when they cough continuously, so they will have this vomiting. Why? Because their LES, lower esophageal sphincter, is not that much tight. That's why GERD is common. So when it is lax, any increase in intra-abdominal pressure, many times parents will, he's crying and vomiting. So post-ossive vomiting can happen normally or after your any kind of howland cough or kind of persistent cough or paroxysmal cough. So it can happen in case of asthma, in case of pertussis, or any condition that is causing bouts of cough actually. If there is a kind of cough which is not very kind of loud or very severe, in that case it may not happen. But it is very common in conditions in which there is a continuous cough, the child doesn't get some time and there is a continuous intrathoracic pressure rise, because the mechanism of cough is that there should be increased intrathoracic pressure, then only you will be able to take something out. So in lieu of that, taking something out from the airway, so these food particles also they get out. And I have already shown in this picture, sir, cough receptors are also present in the esophagus and stomach. So the patient will get their sensation from these two structures. So, and whenever there is some respiratory problem, there may be some irritation in the stomach. Child is not eating well, there may be acidity, something. So that will also irritate. So many times you might have felt that whenever we have not taken something, there is acidity, we also have regurgitation because of that. And we also have cough because there is a receptor there. So there are multiple mechanisms, and these are the common causes like bouts of cough, pertussis, persistent cough, asthma. So they will lead to this cough followed by post-occasional vomiting.
Okay, so I think it is important to know the cause of cough, what is the specific reason, and then treat accordingly. Very commonly in case of viral cough, in case of viral respiratory infection, the child gets all right, his fever is all right, his cold is better, but the cough persists for a couple of weeks. So what do you do in this case?
Yes.
Like parents are
Yes.
pressurizing, then give some medication. So
Yes.
what do you do?
Very important question, sir. I have already that categorically put in my slide. Usually, viruses, they affect the upper airway. The upper airway has a plenty of cough receptors. And this virus, they do not invade deeply. They will cause slowing of this respiratory superficial epithelium. The cough, the free nerve endings, they are exposed now. And the epithelium for healing, usually it will take some time. And it depends upon so many conditions. So till that is not healed, till the time the cough receptors are not covered, child will have cough, and it will vary from person to person. Any disease, any patient is having, not all will respond to same the same treatment. People will respond different to different treatment. So in post-viral cough, what will happen? The cough will be initially more, but gradually it will decrease. So if you ask parents, they will tell that नहीं पहले ज्यादा था अब धीरे धीरे कम हो रहा है. But if after the virus infection, the cough intensity is almost same and it is more than 2 weeks but not decreasing, always think there is an underlying hyperactive ARV disease or some pathology which is not allowing the cough to resolve. So it is beyond viral infection. So if you follow that principle, you will be able to rationally treat the child. So in the first case, when there is a gradually decline in intensity, just wait and watch. But in the second case, if the intensity is same, you have to intervene or you have to poke more into the history. Is there a family history of asthma? Is the child is having hyperactive ARV disease? So those possibilities, or there is something which is there I have missed. You may get a chest X-ray done if the intensity is same. So for that, you need to investigate. Otherwise, you don't routinely investigate in all cases of post-viral cough.
So I think this is a very important point you have mentioned, is that all viral cough they're going to get all right within 3 to 4 weeks. That's why they kept the dividing line of 4 weeks, because
Yes,
4
sir.
weeks plus there is some underlying cause and you have to see. So all viral cough they showed a decreasing trend by 2 to 4 weeks, and they're going to get all right by 3 to 4 weeks. So any cough, if you take a good history and the child is getting better, probably you have to counsel, give them some soothing agent like honey and all, and the child is going to get all right. Then there is one question: how can you differentiate between pertussis and PBB? Just in short, is there any pointer to differentiate between pertussis and PBB?
So pertussis, if you see the child, you can easily make the diagnosis. Protracted bacterial bronchitis, there is a wet cough actually. Okay, rattling sound. Okay, child is otherwise fine. He is feeding normally. He is doing his activity. But pertussis is continuously coughing. You will get telltale sign like suppositional hemorrhage. The child is having whoop also. Okay, child will not look well in pertussis, but in PBB, child is fine. He is coughing. Some sound is coming wet cough, but child is otherwise eating, drinking, doing everything. But that is a persistent wet cough. That is the classical different feature between PBB and pertussis.
Okay. Can pharyngotonsillitis cause a cough or a chronic cough? The pharyngotonsillitis.
Sir, actually, the pharynx have more number of cough receptor. So viruses causes pharyngitis, so there is cough. Tonsils, they have no or very less number of cough receptor. Okay, so that's why isolated bacterial tonsillitis cough will be not there. So if you see MAC exact score or the center's criteria, absence of cough is more in favor of your streptococcal tonsillitis. So that is the differentiating feature.
So I think this message should go very clearly that bacterial tonsillitis will not have cough. If a child is having cough, it is a viral pharyngotonsillitis and you don't require antibiotic. So if you are going to start antibiotic for a child with pharyngotonsillitis, it has to be actual bacterial with no cough. So this is
Yes.
very clear. Bacterial tonsillitis will not have cough and viral will have cough. One question: how to differentiate between bronchiolitis and pneumonia in a child of 6 months to 18 months with fever, cough, and fast breathing. And auscultation is difficult because child is very crying and irritable. So how do you differentiate between pneumonia and bronchiolitis in a child who is 6 to 18 months of age, having fever, cough, and fast breathing?
It's very difficult actually in small infants. So it could be pneumonia, it could be bronchiolitis, but there are certain pointers actually. Okay. So in bronchiolitis, usually, unless it is severe, child is not looking that much sick. But a child with pneumonia with that even moderate severity will look more sicker. Second point, if you see in bronchiolitis, the cough is actually very less. Okay, cough is not more. So if cough is more there, it indicates there is some underlying problem. In pneumonia, again, cough is less, but you will get a combination. Okay, if you compare bronchiolitis to pneumonia, so pneumonia patients will have slightly more cough than the bronchiolitis. Auscultation is very, very important. In pneumonia, you will get either a fine crepitation or a coarse crepitation. But in bronchiolitis, isolated crepitations are very, very rare. If you are getting only crepitations, it will be pneumonia. It is not bronchiolitis. Okay, but you are getting a rattling sound, mixture of wheeze crepitation or some bizarre sound and some gurgling kind of sound that indicate more of bronchiolitis. Again, very difficult to tell in small infants. So you have to keep an eye on them. Better in this case, investigation will help. You send the nasopharyngeal aspirate, PCR. If you are getting any virus, so it is a bronchiolitis. But if you are not getting it, that doesn't rule out. But again, you have to monitor the child, see the response, and you can get take the help of your CBC, ESR, PCT, CRP. Suppose you are not sure. So in these cases, investigation will help. Suppose still you are not sure, get X-ray done. If you are think that it could be pneumonia. So by this way, in labs, you can be able to differentiate. But suppose X-ray normal, counts normal, everything normal. Again, it is 50-50. But if the child is younger, like less than 6 months, chance of bronchiolitis is more compared to pneumonia, but again, there can be overlap.
Okay.
Just want to add one point. In bronchiolitis, we are generally getting more the symptoms and less the signs.
Okay. Then one question regarding the use of cough mixture, like there are a lot of cough syrups available containing ambroxol or guaifenesin and all those things. So just in very short, 1 or 2 lines, what is the role of cough syrups in management of cough, acute or chronic?
I have already read the mind of the delegates. That's why, though it was an approach to cough, I knowingly put this cough mixer because I have already knew that there will be a question on this. So I have shown you the evidence. There is no role of any cough mixer. If you have diabetes, you take insulin. You cannot have like a mixture of in the same series with insulin and you take. There is no point actually. So pointer will tell you anatomical origin, underlying disease. They will tell you the cause of cough. Achha. Most of the time, this cough mixture, they contain agents which fiddle with the cough receptors. If you fiddle, it can cause problem because you don't know what is the cause. Suppose patient is having asthma, you are giving cough suppression, it will cause problem. Person is having bronchiolitis, you are giving cough syrup, it will cause problem. Person is having some thoracic mass that is compressing the airway, continuous dry cough. It will cause problem. Person is having heart disease. So there is no blanket recommendation for cough syrup. Now, if you see one by one diagnosis, tonsillitis, is cough syrup needed? Pharyngitis, is cough syrup needed? Tracheitis croup, is cough syrup needed? Bronchiolitis, is cough syrup needed? Pneumonia, is cough syrup needed? Then for what reason cough syrup? You just tell me. Extrapulmonary causes, GIT, do you need to have a cough syrup? You have a oropharyngeal aspiration, do you need cough syrup? Foreign body aspiration, do you need cough syrup? So I have shown you all condition. Tell me a single condition in which the cough syrup will act. And cough syrup, in fact, is a misnomer. In my last webinar, in IAP NRC webinar, which Ravasara has organized, I showed all the evidence. But you can ask me the question, then why there is a much hue and cry? Why people are using it? Is used in old days. Please remember, that day I showed the trials which were done on cough syrup, 99% were pharma sponsored and they were done before 1996. when the code of conduct regarding clinical trial has not come, like ethical information. So at that time, people conducted how nobody knows. And that evidence is percolating now. After 1996, no cough trial. I have shown in that slide because people fear to do the trial because there is no evidence. So if you ask me, there is, but in my last slide, I showed that like there is a bronchospasm you can use. Again, nebulization or inhaler rather than the cough syrup. There is a weight cough, persistent. You feel there is cystic fibrosis, use 3% saline or hypotension saline, like that. So for specific cause, you have to give. Not like that, patient has come, is not relieved, I will give cough syrup. Cough syrup is like throwing a stone in a kind of night. You don't know where it will hit. It may kill a patient, it may kill a person, it may cause some problem. So in our practice now, if you ask me the experience, we never use any cough syrup and I have never seen any problem in our practice. We work in government, we never, but we are seeing lot many patients. I think that message is clear. Hopefully, I don't know.
So I think Dr. Rashmi, you are given a very clear message is that whenever you see a child with cough, acute or chronic, first try to see what is the cause. Locate the site of airway, whether it is parenchymal, whether it is from pulmonary or extrapulmonary cause. Find out the exact cause of cough and you treat that cause. There is absolutely no role of cough mixture in my management of cough. Only in case of non-specific cough where you are very sure that child doesn't have any underlying disease and it is a non-specific cough which is causing lot of symptom to the child in form of disturbed sleep or vomiting. You can use things like honey in a child above 1 year, which can have a soothing effect. Very small indication of drugs like cough suppressant like dextromethorphan or levothyroxine, that too in children above for 4 years. When you have ruled out any underlying serious problem and it is a non-specific cough, post-viral, where in some children, older children, you can use. For practical purposes, again, the way is that first try to locate the part of the pulmonary parenchyma or pulmonary tree where the disease is occurring and treat that cause. There is no role of cough syrup. So thank you, Dr. Rashmi. It has been an excellent day today for us, and you have given in a very clear terms how to approach a child with acute and chronic cough. I'll request our secretary, Dr. Dinesh Megle, to give a
Sir, we can have the expert opinion also if they want to say something, Dr. Rajesh Tikkas or Dr. Avyukt, if they want to have some comment on.
I have concluded. I have given my comment. Just want to add one point. For the general practitioner or general pediatric practitioner, you have already elaborated there is no role of the cough syrups. But the fixed dose combination of chlorpheniramine plus phenylephrine is banned below 4 years of age group.
Yes.
So we should always follow these things, and we all seen the impact of ignorance of this particular advice of the government in our Madhya Pradesh. So the message to all our pediatrician fellow colleagues are that the fixed dose combination of chlorpheniramine phenylephrine is banned, and government has given the instruction for this particular combination. And our expert, our today's presenter, has already elaborated. Rawat sir has already explained the combination medicines are not indicated as far as the pediatric cough is indicated, is considered. Thank you.
Thank you very much.
Okay, so I'll request Dr. Dinesh to give a vote of thanks, please.
Sir. So, on behalf of MPIP, I am deeply thankful to our esteemed speaker, Dr. Rashmi Ranjan Das, for such a wonderful insight on the acute and chronic cough in a child. My heartfelt thanks to the experts, Dr. Rajesh Tikkas sir,